Okay, great. Okay, so Ivan, yeah, over to you, and thanks so much, Ivan.
No, thank you so much for the introduction, and it's an absolute pleasure to be here. So thanks to everyone for attending. Yeah, my name is Ivan McCann. I'm currently in the role of quality and patient safety manager within a community healthcare organization here in Ireland. So predominant focus in out of hospital care, primary care, older persons, disabilities, things like that. Clinically, I've been a paramedic for over a decade, operated in various venues and things like that, but I've always had a background and interest in patient safety and human factors. And I'll just be speaking a little bit today about scoping review that I conducted as part of my master's dissertation with RCSI and the Human Factors and Patient Safety Program. The story so far. Just to note, I'll give you a little bit of background here anyway, just because we may be familiar with paramedics, we may not be, but in essence, the story of paramedics is a historical one. We can kind of trace that back to the advent of the ambulance during the Napoleonic War, which has been credited to Dominique Jean Leray. And that's kind of where that first iteration we kind of acknowledge comes from. Fast forward to the American Revolution, World War One and Two, Korean War and Vietnam. We see pre-hospital care in the combat situation and scenarios, develop substantially. We can all think of one of our favorite shows, MASH, that kind of out of hospital care delivered in the combat setting. If we fast forward to the 20th century, then a bit further through, we can see the advent of Freedom House Ambulance Service in the 1960s in Pittsburgh, which is kind of accredited to the modern iteration of paramedics. In this cohort, this was all African American volunteer cohort, and this was recognized as kind of the first program, at least in North America, to train paramedics to the level where they're bringing emergency department care to the street. It was an groundbreaking initiative. This has never been done before, and really training paramedics to this unheard standard of care. So today, paramedicine as a discipline has evolved substantially beyond just a traditional role of like a vocational profession that responds to out of hospital emergencies. Similarly, the clinical scope of paramedics has expanded and evolved immensely, quite similar to those of emergency and critical care physicians. And in many jurisdictions, paramedics operate as independent practitioners, with some of them actually being independent prescribers. So while paramedics still traditionally respond to, treat, and transport to hospitals, they also operate across many different fields. We see paramedics operating in primary care, urgent care, intensive care units, both in hospital and out of hospital, aeromedical, retrieval. Probably the most recent iteration is community paramedics, which links, paramedic practitioners with GPs and other disciplines to bridge the gap between emergency and routine care. We also see them in public health settings, as well as industrial, oil and gas, and various other kind of settings where there's a further integration of this profession. So, with all that being said, too, just from my own experience in community health, what we're starting to see now is integration of paramedics into multidisciplinary teams. So moving from operating in small group dynamics, sometimes ad hoc, sometimes established, to larger groups of professionals, all with varying skill sets. So this is kind of where the scoping review idea came from. Really, it was about examining human factors in paramedicine, especially in the context of the rapid expansion and evolution of the role. So this was part, as I mentioned before, of my master's dissertation in human factors and patient safety in RCSI. So we developed our research question, which, as you can see on the screen here, asks how is human factors represented in paramedicine research? Just to note, we used is as opposed to are. So how is human factors versus how are human factors, which I think really maybe kind of are two very distinct different questions, and might highlight some of the misconceptions pertaining to human factors and patient safety if we think to Russ et al. In 2013 did a great article separating facts from fiction in relation to what is human factors. We determined that a scoping review would be best suited for this, given the breadth and depth of paramedicine and human factors. And that was conducted in line with JVI framework for scoping reviews. We developed our population concept and context framework, which is in very simple terms, kind of our search criteria in two phases. The first phase being the population and context. So that was informed by previous work done by Olsen et al., which developed search terms in the absence of a paramedicine mesh term on the databases to really kind of hone in accurate results specifically for paramedic research. The concept portion, which is our human factors concepts, principles, theories, was informed from various literature across healthcare looking at human factors. We established our inclusion and exclusion criteria, and then part of that was no date limits were set, and we filtered our results by English language on the databases. So back in February 2025, we conducted our search. So as you can see, we got a lot of hits. Our total number of articles retrieved across the three databases was 8,500-ish. We screened about 6,400 by title and abstract. About 5,600 were excluded. And then we did full text review for 803 articles. The final number of studies included was 107. So interestingly, in the field of paramedicine, we were looking at when these publications came out. You can see the earliest ones from 91, going all the way up to about 2010. And that's when you start seeing the increase in the number of articles being published in relation to human factors in paramedicine. And that probably aligns with the profession's growth and development over the last 15 years or so. We looked at the number of publications by country as well. So out leading in front was the US, but the UK, Canada, and Australia were close behind. But I think what's really interesting here is the diversity of the countries that were involved in publishing human factors research in paramedicine, which I think is really great and shows that kind of international interest in the field of human factors and paramedicine. So in paramedicine, there's been an increased push, I'd say, over the last decade, maybe 15 years for paramedic-led research. So that was another metric that we looked at as well. So we did see to try and count who was a paramedic conducting this research. We did that by just how the author self-identified in the literature. So 35% of the literature had at least one author that self-identified as a paramedic, either through professional designation, description, or institutional affiliation. That's not to say other authors weren't paramedics, it's just that's the metrics that we use to capture this information. So the results, as we kind of started doing the research and charting the results, we saw that there were human factors domains that began to emerge. In our data charting, we then looked at primary human factors concepts, and then where applicable, secondary or tertiary concepts. So you can see non-technical skills is out in front with 46 articles, or almost 50% of the articles looking at some facet of non-technical skills. So decision-making, leadership, situational awareness, teamwork, things like that. Well-being came up second with about 21% of the articles related to stress, fatigue, or burnout. And then about 20% looking at incidents, adverse events, and errors. You can see some of the other domains here too: patient safety, patient and person-centered care. There's quite a bit of limited research in those areas. Interestingly, just culture, we didn't actually find any articles, empirical research looking at just culture in paramedicine. So what? Why did we do this? Why does it matter? I think really the research attempts to identify in the first instance key concepts in human factors and their representation in paramedicine research. I think it also attempts to kind of collate concepts, theories, and principles from human factors as well. into a cohesive listing, for lack of a better word. So that was the goal in kind of one of the goals anyway in conducting this research. We hypothesized that human factors research in paramedicine would be quite siloed. Again, the majority of the research kind of looking at NTS, well-being, and incidents. I think it's interesting that the non-technical skills focused heavily on decision-making and communication. That's probably going to be quite relevant as paramedics move into their new roles. In the context of well-being, fatigue, stress, and burnout were identified as contributing factors to patient safety events. And interestingly, the management, and I think this is probably the same across most facets of healthcare, has been focused on interventions at the individual level as opposed to the system level. So, that's representative, I think, broadly across healthcare. Burnout, fatigue, and stress also contribute to a high attrition rate within the profession as well. Depending on the tool used to measure, that's a 13 to 56% attrition rate in paramedics. Incidents, adverse events, and errors. They were predominantly explored from the perspective of medication errors and barriers and facilitators to incident reporting. And that was kind of the bulk of it. What we didn't see a lot of, if any, was research into just culture, work is done versus work is imagined, safety one, safety two, person-centered care. And really interesting for me is paramedic experience and perspectives of safety incident reviews and paramedic understanding of human factors. We did see a few articles, where that was attempted. I think maybe two from Finland, I believe it was, that attempted to kind of elicit what a paramedic understands when someone says human factors to them. The bulk, if not all of the research, was heavily focused in the traditional paradigm of paramedicine. So that's responding to out-of-hospital emergencies. So that's not really reflective of the profession's growth and expansion into other roles and environments. So contextually speaking, as the profession does expand into other roles, into other environments, especially in community healthcare, broadly speaking, there's probably further research required to promote that patient paramedic safety in these complex socio-technical systems. So strengths and limitations of our research. As far as we know, this is the first attempt at mapping human factors research in paramedicine. It was paramedic-led research, and we did use a previously validated search strategy specific for paramedic research. The limitations, obviously, as it was a dissertation, it was a single reviewer. We did have some support from volunteers, but obviously that can lend to some bias. Broad human factors concepts. So we went to books, articles, grey literature to kind of pull concepts together and hopefully not make the list reductive, but broad enough to capture everything we needed to. As I mentioned previously, and as I think has been highlighted in the presentation, the profession is evolving quite substantially. So getting a definition of paramedicine is still a work in progress. There was an attempt, I believe, back in 2019, Delphi study to define paramedicine, but other research has come out saying that might be a bit premature at this moment because the profession continues to evolve in multiple facets of healthcare. And we've focused on what's known as the Anglo-American version, or I suppose system of paramedicine, which is kind of what I think most people would be familiar of. It's what we would have here in Ireland and in Canada and the US, where it's an EMT, a paramedic, an advanced paramedic, versus the Franco-German model, which would be predominantly physician-led. So just in conclusion, as I mentioned before, currently the body of human factors research in paramedicine has been focused on three domains predominantly: non-technical skills, well-being, and incidents broadly. There is limited research in other areas of human factors in paramedicine, which again, I think will probably need to be expanded on further because, as the clinical scope increases and broader responsibilities come to the profession itself and interaction with other healthcare disciplines, there's probably worthwhile exploring those. And again, just in the context of those novel roles and integrating into new systems. In my current role in community health, we kind of have a bird's eye view of how multiple systems interact, and there's potential now that we're adding new players into those systems. So likely increased focus is required into that context, into those environments, for both paramedic safety as well as patient safety. And I think generally speaking, paramedics in their generalist roles, there's a really good opportunity to expand into other human factor specialty roles to support the profession's growth. Just some quick acknowledgements. I'd be remiss not to. Michelle, who is my supervisor, my two volunteers, Tyne and Adam, and of course, Dr. Emily O'Dowd at RCSI, all were pivotal in the completion of this project. So I guess we'll take questions at the end, but if anyone wants to follow on ResearchGate, Blue Sky, or check out the scoping review protocol, feel free. You can also contact me at the email below. So thank you so much for your time. I really appreciate it. And I'll pass it off from there.
Brilliant. Thank you, Ivan, so much. And just for those who have joined while Ivan was talking, we're going to have two speakers today, and we'll have questions and answers at the end of our next speaker, Samuel. So we've introduced Samuel at the beginning, but maybe you might just introduce yourself again, Samuel, for people who joined. And thank you, Ivan. So please keep the questions coming in the chat, and after we'll have a Q&A session after as well. Okay, Samuel, so if you want to try and share, that'd be great.
Yeah, thank you very much. I'm going to share my screen. Here. Okay, so thank you very much for your invitation today. I'm going to talk about prehospital newborn resuscitation. I have 20 years experience in the field, had several experiences about unexpected deliveries in this prehospital context. I'm also today the chair of the Advanced Life Support Group, pre-obstetric emergency training group, working group in the UK. And I've been working for several years about around these newborn resuscitation challenges. So just to give you the challenge around these situations, newborn resuscitation is extremely rare event in the paramedic practice. It's about one here in Switzerland. It's about one situation a year for about 60K calls. So it's very anecdotal. A paramedic may experience between 0 to 2 cases in their entire career. It's a situation with a very high stress and cognitive load, with critical decision making in it. And it's clearly not possible to rely on experience. So there is really a work to do to think about how designing things to help the paramedics to do the right things since the beginning of the care. So I worked on these questions, and the first hypothesis I had is that performance depends primarily on the system design. In this context, another thing to know is these golden minutes. In the newborn resuscitation, the first 60 seconds are absolutely critical. It sets the trajectory. So if you manage properly temperature, airways, and ventilation in these first minutes, around 90% of the babies will respond and survive when they have maladaptation to extrauterine life. So these immediate actions are really critical. And when a paramedic crew arrives on site, on scene, they rarely know if birth has already happened. So the scene status can switch instantly in a very high variability of environments, which can be at home, in public toilets, or the backseat of a car. So what I did is use the hierarchical task analysis. So I started by mapping all the tasks that must be done in this newborn resuscitation. I did some observation simulation to gather data and understanding on which were the friction, difficulties, errors there would be in this sequence, which is a very procedural sequence. And after that, I've been working on implementing corrective measures to address the different issues that I identified. So this was done in simulation as a field of study. The population were mainly paramedic students at the end of their training, and also professionals, so paramedics in their continuing professional development. So in the first iteration, 50 scenarios were accumulated to understand what was difficult, what were the frictions in it, and key measurements. So the workstation deployment time, the time to the first effective ventilation, the compliance with the different steps in this golden minutes. With different scenarios which were used from poor neonatal adaptation to respiratory or cardiac arrest. So the metric that was used were mainly process metrics rather than clinical outcome, because it's in this simulation setting. And clearly, something which was really interesting, that simulation became an ergonomics laboratory for these rare events. So the main idea was to use all this simulation to identify these difficulties and see where errors were and how we could work on it. So the first results and the main bottleneck was the preparation and the setup of the proper workstation. And it clearly showed that if there is a bad start, it creates a depth of attention, and we end up chasing after task. So if it's not properly set, if it's not properly set up, people will try to start ventilation, for example, and at the same time will try to continue to set up the workstation, and this will how can I say it? Involve a cascading effect of errors and omissions. So the conclusion of this first iteration was that the first lever on which I had to work on was addressing the workstation preparation. So this is the hierarchical task analysis. I will zoom in a moment. So on the left side is all the tasks linked to the care to the mother after the delivery, and on the right side is all the tasks are on newborn resuscitation. These are all the tasks that must be done in this first minute, in this golden minute. So it's nearly 23 tasks to achieve in a minute, which is highly challenging. And also considering that paramedics will experience this maybe 1 or 2 times in their career. So very high stress and very high cognitive load. So just to focus on a part of this task analysis, the parts in red were where I had the most errors in it. And the arrows between the different parts are just showing how it induces errors in the next steps. So clearly, most of the errors we had at the beginning was in the setup of the workstation. And the main idea was to redesign the obstetric pack to make it pre-configured and deployable within seconds. So the concept I worked on was a workplace in a bag where the storage guides the hands and where the configuration of the workplace reduces variability and time spent on these useful tasks. So the principle was make the right action the easy action. And the main idea was that they could grab the workstation in the bag, put it on the table, deploy it, and it was ready to use. This is the photos of one of the prototypes. So in the bag, and once it's deployed on the table, and all the material is already ready in it. So when you open it, you already have access to all the proper material to work on it. And once we worked on this prototype, we tested it in different versions. And after that, I redid hierarchical task analysis and tried to understand where were the next errors. And we realized that this problem was solved, but we had another problem in the simulation. And it was with the algorithms of newborn resuscitation. On the left side is the old version, and on the right side is the new version. And in the middle of the algorithm, participants were very confused with the arrows going on the left, on the right, down and up. So it was not easy to understand which were the next steps in a very high cognitive load and very stressful situation. So I've been working on the right side to redesign this algorithm and make it more visually understandable to understand, and to make very clear the 3 situations you could have after this golden minute and which task has to be done in it. So this was the second iteration with some design about the algorithm. And on the third iteration, we worked on a sort of a pit crew organization. So the main idea was to get inspired by pit crews in Formula One and take some ideas of it and to transfer it in this setting with a clear distributions of roles and tasks upon arrival. What we observed was that when the paramedic doing the ventilation was trying to do something else at the same times, the quality of ventilation decreased dramatically. So the main idea was to separate roles and tasks and allow the paramedic to have a low level of task, a low number of tasks, and to concentrate to achieve them in the better way. So we've separated the basic life support and advanced life support and worked on separating the task. And after that, things were done in a really proper way. So we had several iterations, design, tests, and learning. This repeated simulation testing allowed us to adjust between each cycle as a PDSA cycle. And the main idea was to modify the design until the design guides the hand. The effects we have observed is a clear reduction in the omission regarding this temperature, airway, breathing, circulation algorithm, a shorter workplace deployment time, and from an average of 4 minutes to 20 seconds, which was very critical in regard of this golden minute, a better compliance with the critical steps of this golden minute. So now we are working on the new guidelines, which were released yesterday. And we are thinking about what other new thing we could work on. We didn't have to promote it in the ambulance services because all this was done in a school and in training and simulation. But what we observed is that the trained paramedics who were convinced from the benefits of these different solutions become our sort of champions and bring these practices back to their organization. And there is a sort of organic adoption now in French-speaking of Switzerland of the bag, the algorithm, the pit crew organization. So in conclusion, 3 key messages. When you work on design, make it the right action, the easy action, simplify cognitive aids as maximum as you can. And when the practice is rare and scarce, simulation is a really interesting ergonomic laboratory. Thank you very much.
Really, thank you, Samuel, so much. Thank you very much. And just encourage people to turn on their cameras for the Q&A. And we have some questions already in the chat. So we'll start with those. But if anyone has a question, just put up your hand. So Ivan, Mike, I think I started off the question for you. I think it's fascinating when you review the literature. I really liked your human factors for the science of human factors. That's great. But just did the study self-identify as human factors, especially the kind of well-being study, or did you have a criteria as to what was the human factor study?
Yeah, so it was quite interesting. So the number of studies that came up specifically with the term human factors was few and far between. I think 3 or 4, which I think kind of speaks to a broader, maybe broader misconceptions across kind of healthcare, anecdotally speaking. And I don't know, maybe Samuel, you might be able to relate to this as well as a paramedic. You know, from my own experience, when I say human factors, people automatically go to crew resource management, you know, these kind of facets of it. So most of the studies didn't self-identify or weren't necessarily labeled as human factors. They might have been in the you know, the keyword section. So when we built out the concept portion, we kind of went out to whatever literature we could find. So I'm thinking of kind of some work by Catchpole. There's a great book for paramedics, Human Factors in Paramedic Practice by oh, his name's escaping me now, but to try and pull those kind of concepts out. So while, you know, fatigue, stress, burnout weren't necessarily labeled as kind of in the context of human factors, we included them within our search parameters based off kind of the broader literature as it pertains to patient safety and paramedic safety, broadly speaking. So, yeah, I think, and I don't know about other industries, but definitely in healthcare, there's still some maybe misnomers about what is human factors versus what are human factors.
Yeah. I think I'm having problems with my sound, but Liam, do you want to just ask your question and I'll run and get headphones?
Yeah, sure. Thanks, Ivan and Sam. Sam, my question's for you. Is there like an equipment and pack prep instructions list that you have if other people wanted to trial the work that you've done so that they don't have to go and do it themselves from scratch?
No instructions for the moment. But if people would be interested in it, I will be happy to share my work. And no plans for the moment to spread the work in other geographical areas. But maybe at some stage I could work on a publication, and we are also aiming to do another edition of the pre-obstetric emergency training book, and it's probably we be in the book the good practices we found.
Okay, great, thanks.
Hopefully my sound is better, is it?
Just very quiet.
Okay.
But no more echo.
Ivan, you have a question for Samuel?
Yeah, first off, great work there, Samuel. I really appreciate all the work that went into that. Just a couple quick ones, just my own curiosity there. In your region there, what's the usual crew setup when responding to like an out of hospital birth or neonatal resus?
Well, it depends on each district, more or less. You mentioned in your presentation the UK American model and the French and German model. And in Switzerland, we have a mix of the two of it.
Okay.
To give you an idea. So in an ambulance, you will have a paramedic and an EMT, or two paramedics, and you will have a paramedic with an emergency doctor to reinforce some situations. And on delivery in general, you will have a paramedic crew and an emergency doctor with the paramedic. And depending on the district, you will have a neonatal ambulance who come and reinforce the situation.
Great. No, that's awesome. And then just my second question then, absolutely love the algorithm redesign. I know there's nothing worse in a kind of high stress situation than arrows pointing you every single way. So that's great work there. And I was just wondering, and I'm not sure if I caught it when you're during your presentation, but does that algorithm redesign kind of align with the steps for the resuscitation pack? Like if step 1 in the algorithm says X, Y, and Z.
Yes, it's linked. Well, it's linked to the national guidelines, and it's linked to the back indeed. Yes.
Great, that's awesome work. Thank you so much.
Thank you.
Great. Any other questions for either of our speakers? You can just turn on your camera or just open your mic. No, I think it's great. It's amazing work, and it's lovely to see the cross-cultural perspective. Samuel, I love your points on simulation. You know, I just think it's so important we have such a tool as simulation to use and to try out and to keep people's skills current. If these are such rare events, you know, so it's great. And we have we've programs here in Ireland on simulation as well. So it's inpatient safety, which are brilliant, a master's program over in Galway. So look, if there's no other questions, we'll close it there for today. But just delighted, and thanks so much to you both for coming to speak with us. We run these webinars monthly, so same time next month. It's usually the last Thursday of the month, but because of Halloween next week, we're a bit early. And then we have our in-person lunch and learn event for the society on the Monday, the 8th of December. So please stick that in your diaries and keep that free for our next in-person gathering. Okay, so thanks a million, everybody. Thank you, especially Samuel and Ivan. Great presentations there. Thank you. All the best, everybody.
Thank you very much.
Excellent.
Thanks, everyone.